Welcome and thank you for joining us for tonight's session, Demystifying Dementia Part 2. My name is Sydney and I'm from the PHN Education team. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For me on the Central Coast, that is Darkinjin land, and I'd also like to pay respect to elders past, present, and emerging. Now, a few things to let you know about this session. It will be recorded and available for you to view in our education library in a few days' time, as well as a copy of the presentation slides. Now, as attendees, your camera and microphone are automatically disabled. So if you have any questions throughout the presentation, please pop these in the question box, which you will find located within your control panel, and we'll go through these at the end of the session. Now, an evaluation will also come to you directly after this session. Now, your RACGP number was not asked in the registration questions, so it's really important that you fill this in so we can capture that so we can upload your CPD hours. Now, before I hand it over to our speakers from part 1, it is my great pleasure to introduce one of our Health Pathways clinical editors, Dr. Li Fong.
Hi, how you going, everyone? Thanks for joining us tonight. And just a quick word. Don't you hate it when you're at a lecture or a webinar and you're madly scribbling things off the PowerPoint slides and you're turning yourself into a human photocopier rather than being able to focus on the content? And then you copy all that stuff down, it's in a note somewhere, and you've got no idea where you've left that note at the point you need it. There is a solution, and you're seeing that on your screen now. It is, of course, Health Pathways. So I just want to give you a quick note at the beginning just to say that the current dementia pathways have been reviewed to be in line with the material that you're going to see tonight. And in particular, a couple of the pathways, there's one called dementia and cognitive impairment, that's been very specifically aligned with what you're about to see, as well as another one, which is called medications in dementia. And on top of that, there's 2 completely new dementia pathways that have been created to fit the content you're about to see. One is fitness to drive in the context of cognitive impairment and dementia. And there's another one, behavioral and psychological symptoms of dementia or BPSD. So just be aware that those pathways are available. Follow the QR code or the link on your screen with the username and password to get on, and on with the show.
Hello and good evening. So tonight, my name is Stephanie Daly and we met you a couple of weeks ago, and I've got Pete Silberberg back and Rebecca Moore, and we're going to talk to you about demystifying dementia for post-diagnostic support. So just to recap, our acknowledgements are the same as before. And we do have some outcomes, learning outcomes tonight, and hopefully you'll be able to review the frameworks that we talked about last week or the week before and use these to assist in implementing a diagnosis and also supporting people in post-diagnostic care. So as you remember from last time, we do like to begin with the end in mind. And for most people, we recognise that the GP can both diagnose and initiate care, that a timely diagnosis improves outcomes for both the person living with dementia and their carers. And despite there being no curative treatments for dementia, there are lots of interventions that we can provide that can improve quality of life. So if you can go away knowing those few things, then we've probably done an okay job tonight. So, Pete, I wonder if you could just run through to remind everyone and anyone who wasn't here last time, the domains of dementia so that people have an idea how we're going to set the scene for management.
Yeah, thanks, Steph, and g'day everyone joining the meeting tonight. So we try and think about dementia from a very holistic whole person perspective, and we have devised 5 domains to characterise a way of thinking about both diagnosis but also post-diagnostic care, which we're talking about tonight. So you would have seen these 5 domains in the first webinar in terms of diagnosis, but we're going to use the same headings for diagnostic care. And you can use the same headings for many illnesses, but this is going to be through the lens of dementia. So initially we've got cognition, which is of course not just about memory, but about attention and processing and insight and judgment. It's also about things like function, and particularly change in function over time around things like activities of daily living, such as the ability to go shopping, clean the house, do the cooking, drive the car, do the banking and those kind of things. And then there's potential for psychiatric symptoms, which may be a reactivation of something that previous, or they may be specific to the dementia process themselves. And they fall under similar categories to what you'd be familiar with, such as depression, anxiety, and sometimes you can also have psychotic symptoms in the form of hallucinations, which tend to generally be of a paranoid nature. And then there are behaviour changes, which are a result of numbers 1, 2, and 3, and also partly of the dementia itself. And often people living with dementia may become withdrawn, a bit apathetic towards life. They may have behaviour which is disinhibited. If there's a frontal component of their dementia, they may wander out the house. They may do quite odd behaviours that they're not used to in the past. And then lastly is physical decline. And people obviously, as they get older, can undergo physical decline. But there are some specific parts of dementia that we're talking about here, and they're specifically around things like mobility and the ability to walk and balance and move around, and swallowing would be the other one that's important, and control of continence, but all parts of physical.
Great.
Thanks, there's a lot of summary for you.
And do you think you could run us through the stages as well? Because we're also going to use those tonight to kind of focus our post-diagnostic support.
Yeah, that's right. So hopefully these look familiar to what I did the other day. And so just to remind people that we like to use the word stages rather than mild, moderate, severe, which can tend to be judgmental to the person sitting in front of you. So what you might consider to be mild, they might consider to be severe. So it's not necessarily a helpful word. So we refer to the word stages. And it is a disease that progresses over time. And so it's fair to have stages 1, 2, and 3. And this is a really useful thing to think about when the person's sitting in front of you and you're trying to think where are they in their journey and where are they heading to next, so you can plan for the next phase. And that's particularly important tonight when we're talking about post-diagnostic care. So in stage 1, the person with dementia, they're still living in their home. Their ability to carry out ADLs is still fairly intact, and you know, they're still functioning reasonably well. Well, they may be a little bit more advanced than that, but they're living with someone who can help them, who can you know, assist them with some of the issues that they're having with their cognition, their behaviour, etc. And then as that progresses, they can move into stage 2, where their care needs escalate, and eventually they're needing a transition to 24-hour care, and that leads to stage 3, usually meaning that the person is transitioned to a residential aged care facility. And you can see there on the slides too that, of course, with those stages, the domains change as well and become more significant. Do you want me to do this one too, Steph, while I'm on a roll?
Yeah, keep going.
And then I'll be quiet and let Beck have a go. This is to put it all together. So again, we showed this slide last time. So you can see at the top there, the stages 1, 2, and 3. And then put across the page there are the different domains. And of course, this is a representation. It's not the same for everyone. This is more of a classic Alzheimer's disease presentation. It may be a bit different. If it was more of a vascular, it would certainly look different if it was frontal. So again, this is more for Alzheimer's. And the bottom there from 0 to 10 years, again, that's an estimate. Some people go faster, some people go slower, but that's about an average. And you can see there that as you move through the different stages, your cognition and function decline. Now, it might not be linear like in that, but they do decline over time. The psychiatric symptoms and the behavioural changes tend to waver and go up and down depending on the, you know, what's going on in the person's life and how they're reacting to things in their life, like in everyone else who's maybe experiencing those symptoms. And then the physical changes from dementia, as opposed to something else, some other sort of illness in that person, tend to be in the stage 3. And then you can see in stage 3 that all the lines intersect and cross and look very messy, and that tends to represent sort of what's going on in the person's life at that time. Things are very chaotic, families generally struggling a lot, and that's when the person is generally transitioning into 24-hour care. And I guess this is another representation about why early diagnosis is so helpful, because you can plan ahead and you can do lots of stuff while cognition is still reasonably intact.
Perfect. And we're actually going to be focusing on stage 1 tonight for management, although we do actually have some information on our website about stage 2 and 3. It's just such a, as you can imagine, vast time in someone's life that we can only really focus on a small part today. So Beck, can you just quickly run us through the inclusion and exclusion criteria, just to remind people from last week very briefly how we make a diagnosis of Alzheimer's disease?
Certainly. So we've been predominantly talking about Alzheimer's and vascular dementia. I mean, a lot of what we covered tonight will also be pertinent to the other subtypes of dementia. But in Alzheimer's and vascular, essentially, we need to have evidence of a change in memory, which is worsening over a longer period of time, so a gradual onset. In addition to that, for a dementia diagnosis, you also need to be able to show some failure in function, which is that ability to perform activities of daily living. So to show that there has been a clear change in capability in things, as Pete said, like the cooking and the cleaning and the shopping, etc. And then finally, some evidence of cortical dysfunction. So this can be often in the form of language, so difficulties in word finding or changes in conversation, difficulties recognizing faces, familiar people, objects, and other things such as a dyspraxia. So, for example, people are having difficulties using the remote control, or trying to sort out the air conditioning, or how they open up their Excel spreadsheets, etc. So essentially, for Alzheimer's and vascular, you do need to have all 4 of those, although I always have that caveat that if they don't have these problems particularly in the memory domains, but you still have concerns, I think it's still appropriate and pertinent to seek further assistance. And then I think if we move to the next slide, we're going to talk also about the things we have to exclude. So in order to be able to make a diagnosis of dementia, you need to have excluded, or certainly reversed and managed, any features of delirium being that more acute onset of confusion which fluctuates and is associated with inattention and a fluctuating level of alertness. You need to look for other organic causes, the metabolic, endocrine, medication, vascular, structural causes, and wherever possible, treat and reverse these. And also consider other causes in the terms of psychiatric illness. So making sure that the person isn't experiencing significant depression, which might affect how well they're performing on their cognitive assessments, and also excluding other conditions like anxiety and some of the psychoses. I think that covers it. Would you say, Steph?
Perfect. All right, so we're going to just make a little segue and imagine that we're back in time. So we've got our case presentation. That's Anna, who's 75, but we're going to imagine that we've seen Anna as a regular patient from probably her midlife and at the age of 50. And we're going to talk to you a little bit about a concept called a brain health check, which is similar to a heart health check, but just focusing on the brain. And this is because a few years ago, while everyone was worried about COVID, the Lancet Commission finalised a synthesis of lots and lots of evidence from around the world about the modifiable risk factors for dementia. And they have basically put forward a call to action that it's never too early and never too late to actually implement some of these risk reduction strategies. And so I think, and the team at DTA think, that this is something we can easily do in primary care, because we're so used to doing preventative medicine, that if we just kind of flip our thinking a little bit from heart health to brain health, we might be able to actually implement some of these risk reduction strategies and also destigmatize what is a very stigmatizing condition, so that when Anna becomes 75, she actually has the confidence to talk about her symptoms, and we have the confidence to ask about her symptoms. So that is what we're going to talk about now. And I'm going to get Pete to talk you through how you might implement a brain health check, which we've essentially kind of invented for primary care, into a primary care consultation. Okay, Pete?
Thanks, Steph. I'd encourage you to have a look at the Lancet Commission report. It's freely available online. I don't know, Steph, if we're able to message people during the webinar, but we could maybe even send you the link. It's a really great summary of dementia and the risks involved, and essentially they believe that 40% of what's going on in the pathology behind dementia is what could potentially be caused by reversible risk factors, and which means there's 60% of going on that we're not quite so sure about. There are, around sort of the pathophysiology of the amyloid hypothesis and the tau hypothesis and that kind of stuff. But 40% is potential reversible. And then they divided the risk factors into early, midlife and late life. I'm not 100% sure, maybe Steph might know about why, they did that actually, because I would have thought smoking is something that happens all through your life, but there's some statistical reason why they've done that. I couldn't tell you tonight.
I think it's to do with where the evidence is that the damage occurs. So, for example, you might have diabetes in early life or midlife, but like you don't get the secondary complications until later life. So it's about when you see the pathology most impacting, but you're obviously not going to just target those things later in life. That's how I understand it.
Yeah, I mean, I sort of understand it like that too, because if I look at something like depression, I think if you had recurrent depression your whole life, I think that's significant too, rather than just having an episode after 65. But look, we don't have to argue about that because we're not the authors. It was just more me trying to explain the headings there. The most important thing is to have a look at what's inside the headings, and it's kind of, you'll notice a lot of those headings there, and just think about it like vascular disease. So there's hypertension, there's obesity, there's diabetes, there's smoking, there's physical activity. And then you need to add in some ones that are specific to dementia. So education, especially in early life, is very important. Not something often is reversible that we can treat as GPs, obviously, but worth noting. And then later on, the other one there you may not be aware of is hearing loss. So this is quite a significant association between hearing loss in midlife and developing dementia in later life. And we're not quite sure about why that is. There's a few different theories around. Potentially it might be input into the brain. It might be that some people with hearing loss have very microvascular changes causing the hearing loss, which might also be associated with the dementia in later life. I'm not really sure, but it's definitely there. And so I have a lot of patients who are in midlife who have hearing loss and don't find, it's a bit of a stigma. And if you convince them to get that treated with a hearing aid, that can potentially reverse the risk factor. TBI probably is in the press a lot. I won't talk about that. I'm sure that's probably something you're aware of. Alcohol is not well known, and certainly my patients aren't alert to that. And I find that to be a really useful tool in motivational interviewing. I have in one of my practices a high number of patients and around the age of the mid-70s, and a lot of them spend their time drinking wine. And commonly, 3-4 glasses a night, 3-4 bottles a week, and that even though this is later in life, that still has a significant impact. And so I find saying things like, were you aware that alcohol is a risk factor for developing dementia later in life, earlier than perhaps that you would have thought, is often a good motivational interviewing technique. And then later in life, we talked about depression there. and that includes some of the other psychotic illnesses too. We're not quite sure of the process there, but there might be something going on that happens in the brain when people have very severe episodes of depression and psychosis that contributes to dementia later in life. Air pollution is a new one that they added in 2020. Fortunately, not a big factor in Australia, but certainly is overseas, and this is a world report. And then social isolation will be the other one, and we're going to talk about that as part of something that you need to talk to patients about. But people who are at home, isolating themselves from the world for whatever reason, maybe they're depressed, maybe they don't have a social network, for whatever reason, that they're at greater risk. So that's risk factors. And then what is a brain health check? Well, like Steph said, it's sort of a term that we've at DTA coined. So you're not going to find it if you go into in the MBS and look online. You won't find it. There's no specific item number. Although, wouldn't that be cool if anyone out there on the webinar is from the government? Please listen. But it's basically an opportunity to do what we just talked about. Promote and optimise the individual's brain health. And you can do that at any age, but midlife seems to be a time that patients come in and say, hey, can I have a checkup? I've just turned 50. My wife sent me in here for a prostate check, whatever. It's, there's lots of opportunities in midlife. I know people doing lots of women's health talk around it, around women coming in wanting to talk about menopause and HRT. So there's lots of opportunities. And there are some evidence-based tools that we can direct people to as well, which we're going to show you in a sec. So what can you do within the MBS? So you can do a 45 to 49-year-old health check, which uses the same item numbers for an over 75. So once you're getting over sort of 40 minutes, they're fairly well remunerated. And you just need to have a risk factor for developing a chronic disease. So if you had any of those risk factors, obesity, smoking, inactivity, social isolation, history of depression, hearing loss, if you've got any of those under MBS, you would be entitled to talk about this and include that as part of their health check. When you get over 75, there's the annual health assessments, which I'm sure most people are doing. And then you can do an annual health assessment at any age if you're identifying as Aboriginal and Torres Strait Islander, or if you're living in an aged care facility, or if you're living with an intellectual disability. So they're the other ways you can do this. In fact, in the Aboriginal health assessments, which I also work in the Aboriginal Medical Service, the health assessment for over 45-year-olds has just added in a question around memory. So for those of you who work in that space, that's important to add in too. And then if you do identify someone at risk, this is an evidence-based tool that you can direct them to. So, and we'd encourage you to maybe have a go at doing this yourself, even just because it's good to do what you're asking your patients to do sometimes. This is an Australian developed online assessment tool, and you can answer a series of questions over about 20 minutes, and then you come up with a risk assessment, and it can tell you sort of where you can improve and when you're doing really well. And then the patient can, they can bring that back to you, and you can have a bit of a chat about it too. So that's a pretty cool thing, and it's very cool that it's in Australia. There are some that are overseas too, but this is an Australian developed cognitive assessment tool.
Brilliant. Thanks, Pete. So so if you're looking to do anything for your measuring outcomes, reviewing performance or improving performance, then instituting a brain health check or disseminating this information amongst your practice would definitely tick that box. And as I said, it's not a great leap from what we already do. It's just reframing things with the dementia lens, I guess. So now we're going to go back to our case. So we're whizzing. I was watching Back to the Future at the weekend. So we're whizzing forwards in time to Anna, who's now 75 years old. And she's living by herself. We met her last time. And she had attended with her daughter, and we watched a little vignette video of Anna presenting and the history that she presented with. And after we watched that, we talked about examination findings and her cognitive assessment tool findings, and that she wasn't depressed. And we felt that she met the inclusion criteria in terms of having memory that was getting worse over time. It was impacting her function, and she did have evidence of cortical dysfunction. And we excluded all of the 3 exclusion criteria. And so at the end of that, we felt pretty confident that Anna probably had a diagnosis of Alzheimer's disease dementia. But we stopped it at that point, and we didn't actually talk about the diagnosis. How do you actually talk about diagnostics, or deliver the diagnosis, I guess? And one of our colleagues who works at DTA, Hilton, coined this term of giving the gift of a diagnosis. Now, it might seem a little jarring to think about the diagnosis of Alzheimer's disease as a gift, but for some people who are very anxious and worried about what is happening to them, actually to find out what's happening is somewhat of a reassurance, because otherwise you're just kind of living in limbo, feeling very confused about what's going on. And it allows time to institute lots of things in management and post-diagnostic support that can actually improve the quality of people's lives. So whilst it is a serious diagnosis, it is a life-limiting condition, it is something that people live with for a very long time, and we don't want people to be living in poorer circumstances because we didn't feel able to talk about that diagnosis. So hopefully, I'm hoping that this video is going to work, Sydney. Otherwise, I'm not sure. Do I have to do anything to allow the sound to work, or I just press play? I think I just press play. I'm going to give it a go. All right. Has it changed my screen? Yes.
I'm not getting any audio, Steph.
Oh, no.
Yeah, I can't hear it.
What do I have to do to allow audio?
Steph, sometimes it's just an issue with the different types of videos, and we might not be able to get the audio from it.
Can I post it into the, can I post the video into the chat? Can I do that?
Do you want to add the link into the chat for everyone and see if that goes through?
That's gone to organisers. Oh no, how do I do it to everyone? Organisers, panelists. How do I do it to everyone?
I can do that one, Steph. Here we go.
Okay.
There we go.
People just need to watch the first 30 seconds and then come back, if possible. Hopefully.
Do you want to stop what you're already playing? Yeah, so,
I'm not playing it.
oh, you stop playing, okay.
Yeah.
All right, I reckon that's probably time.
Okay. Now I just need to share my screen again. Hang on. And I can't find the thing's gone missing. can't find my keynote thing now. Oh. Ah.
You're getting there, Steph.
I can't find it. Hang on.
Just I hope you've got nothing inappropriate open on your desktop.
No, it's pretty okay.
We've lost your video too.
My video?
Mm.
You want to stop sharing until you get your power. Here we go.
I can't find it. It won't come up for some reason.
All I see is a Mac and go, oh God, it's a Mac.
I don't know why. Like, it's there, but it won't open up. You might have to share it, Sydney, and I'll just tell you to tell it. I don't know how come it's gone. Hang on.
Give me a second and I'll get it up, Steph. And what slide number were you on?
15. It's just disappeared.
Would you like me to talk a little bit about the video, Steph? Would that help?
Yes, that would help. So could you tell us, how did you feel the doctor did, Dr. Hilton, actually Dr. George, in terms of delivering the diagnosis?
I think Dr. George did a very good job. I think there were several things that that are really important when you're giving a diagnosis, such as delivering the diagnosis of dementia. Firstly, as you've said, it's really important to actually give the diagnosis. Secondly, I think to use those dementia-specific sort of language guidelines that we talked about last session, and also making sure that you're talking to the person themselves as opposed to the person that they've come in with is really important. And Dr. George did all of those things very well. I liked the way at the start he reassured them essentially that all of the tests had come back as normal. And I also liked the way that he gave Anna some time to process the diagnosis and the information. And then I think her daughter almost clarified it, saying, "What you mean Alzheimer's?" And that was a good segue for him then to reiterate, yes, that was indeed the case. And I think he left enough time and a sort of open-ended sort of question really for Anna to then talk a little bit more about what it meant to her. I think I mentioned last time, it's a really difficult thing, I imagine, as a person to learn that you do have a diagnosis of dementia, because I think automatically it's immediately changed perhaps how you view yourself and potentially how others may perceive you as well. And I think we can't ever underestimate the effect that it can have. And I do think another thing that in my reading and talking to other people, one thing that sometimes I certainly in the past have shied away from is possibly not necessarily giving a diagnosis, particularly to residents in nursing homes where there's almost a presumed or a presumption that there is a dementia there. But I have started now to actively acknowledge that there is a diagnosis, and I think that that's helpful both for the person as well as for their family too. So I think that's another thing for us to just bear in mind as GPs, that having a diagnosis I think is helpful for the person, for their family, and also in the nursing home situation for the staff looking after the residents as well.
I mean, if you think about it, it being a terminal illness, there aren't many other terminal illnesses where you don't tell somebody that they have a terminal illness.
Yes, that's right.
You know, so it is relevant at any any stage, because particularly if somebody is going to die from that illness, you need that, and you need to explain what the cause of their deterioration is, and that helps with care planning. I just think we all feel bad for that person, because we all imagine how awful it must be to have that diagnosis received, but actually you've got to think about all the things that it enables you to be able to do for that person. Yeah.
That's right. Yeah. And I do think in this case too, this highlights how beneficial it is to have a GP who knows the person, who knows the family as well, and obviously has been looking after Anna for a long period of time. And I think a lot of us are blessed with that opportunity to really have an understanding as to how this could impact things in the future. And I think, again, you know, as GPs, we are well placed to deliver a diagnosis such as this.
And obviously the information that you give afterwards is not going to be necessarily at that appointment. It's the same as any kind of breaking bad news. You kind of will need to have lots of other appointments after that. And that's, again, the benefit of being that person's general practitioner, is that you can actually schedule that in, rather than when people receive a diagnosis from a specialist, it might be sort of 3 months or 6 months before they see them again. And so they, you know, lack that ability to come back and ask questions. So that's what we can be there for. Anyway, so we better get on with actually what management do we institute after we've made that diagnosis. So if we can move on to the next slide. This is just to highlight that whilst we're thinking about the stages, at DTA we have a main theme for what the stages actually mean for that individual, and it's about the preservation of dignity. So we've talked a lot about keeping the person central and instituting person-centered care. And again, this just comes back to that message that we need to maintain that individual's dignity and autonomy for as long as possible, and dignity throughout. So if you have that just in the back of your mind when we're thinking about management, that on post-diagnostic support, really, that will really help you to frame what the best things to do are. So Pete, I'm going to bring you in now. We're going to talk about stage 1 and cognition. How do we support people with their cognition in stage 1? So if we move on to the next slide, this is just to show you that we're going through the different domains now, starting with number 1. Next slide, please.
Thanks, Steph. So, yeah, we are going to go through each domain individually, and there's, of course, the massive crossover between all the domains. So you might think, oh, this is more behavioural or whatever. So, you know, we accept that. But where we think this is useful is that it just helps divide up quite a large sort of process that you have to walk through with the patient and their carers over a number of visits. So it doesn't all happen in one go, for sure. And at least what I do for myself is that I have a shortcut that embedded that I can bring up straight away. I can dot points under each domain, and then each visit I just slowly chip away at them until they're done, and then I can keep revising them as I go. So let's start with cognition. So, you know, the sorts of problems we're looking at here are around memory, but it also might be around, you know, word finding or difficulty planning or judgment and insight. They're the sort of things we're thinking about here. And in terms of what you need to do, so first one is have a look at what tablets the patient is already taking. So there are many medications that can affect cognition, and I think we've got a slide coming up perhaps with a bit more of that. Or we talked about it last time, but there are, you know, obviously the classic drugs that have anticholinergic side effects like amitriptyline, you know, the antipsychotics, some of the antidepressants, you know, and the bladder antispasmodic drugs. All these medicines can affect cognition, and if they're already on these tablets, then you need to review that and potentially stop them and see if there's a benefit. And if you're still unsure, then by all means get a second opinion through a home medication review. cholinesterase inhibitors is second. I'm just going to leave that for a second. So the other thing you need to do is have a think about their cardiovascular risks. So make sure that you're still controlling their blood pressure appropriately and their blood sugars, and you know, emphasising exercise is really important. Trying to make sure that they've stopped smoking. All of those standard things you do for someone with, you know, heart disease or a stroke, you'd also do with dementia. Just a note on that, you wouldn't be starting someone on aspirin or a statin after a diagnosis of dementia, though, like you might do so, for example, after a diagnosis of a stroke. But you certainly do want to control their cardiovascular risks. Education is really, really important, because the carers are obviously anxious and concerned, like the person is sitting in front of you generally. Like we've shown in that slide earlier, this is a condition that lasts for years, and it's an ongoing process in terms of education. And if the person living with dementia and that you've made the diagnosis with in stage 1, then, you know, emphasising to that person and the carers that we're in a stage where we're looking at keeping you at home, because most people have a fear about being put in a nursing home, and that you may not need to stop driving, and that, you know, talking them through sort of, you know, what it is, what is it that you enjoy in your life. So doing a sort of a person-centered approach. I like hanging out with my grandkids. I like doing the cooking, the gardening. Well, let's work towards ways of making sure that you can maintain those things in your life still. Is a really good way of framing it. That's how I do it. If the person still does have capacity to understand what's going on in terms of their health needs, then you can certainly, we would encourage you to either revise or complete your initial advanced care plan, and have a talk to them about whether their legal documents like their will and their guardianship are up to date. And, you know, if there's difficulties around family dynamics, around money and wills, that kind of stuff, then definitely get a second opinion, or I would suggest you get a second opinion either from a geriatrician or some other specialist. And if you're still stuck, you know, call your medical defence union and get them to give you some advice. So there are, hopefully, in your area, there are some allied health professionals you can refer to, and we're going to talk a bit about that too under the behavioural domain, so I won't talk too much about that there, but they also may be able to provide some support around cognition. And then the last one, which was second on the list there, but I'm putting last, is the cholinesterase inhibitors. And the reason why I'm talking about that last is because I know that that's the one everyone kind of says, oh, what drugs can we give them? And the patients say, you know, what medicines can you give me? Because that's the framework we use for a lot of things, isn't it, in medicine currently? But at the moment, in this space, the current medications, which we are going to talk about, they've got mild benefit, and the other stuff you're doing there around the medication review and the education and you know, making sure the person's engaged socially and with their community, and they're not staying at home by themselves, and these kind of things, they're all just as important and have equal benefit to cognition than putting someone on a cholinesterase inhibitor. So that's that. I think the next slide is about the cholinesterase inhibitors from memory, Steph. Do you want to? There it is. Yeah. So the main one that you're probably used to is donepezil or Aricept, but there are different versions of that. They all have similar benefit, whether you're using a patch or a tablet. And if you are thinking about starting someone on that, there are some PBS criteria that you need to follow. It's for Alzheimer's dementia. The mental state score has to be over 10, which is a frustrating criteria because the person might have English as a second or third language, or you may have used a different cognitive assessment tool. So I won't talk about that too much, but it is a bit frustrating. And it needs to be in consultation with a specialist. So that can either be picking up the phone and having a chat to them. I've also emailed a referral with quite a detailed summary using the domains, inclusion, exclusion criteria, And the geriatricians emailed me back and said, yeah, I agree, that looks like Alzheimer's. Can you please commence donepezil this way, you know, starting at 5 milligrams for 4 weeks and up into 10 as long as you're monitoring for side effects, because I won't be able to see them probably for a few months. And hopefully other people can have that same experience. And the way Steph has taught me to describe how to use this medication to patients, which I really like repeating, is to say something along the lines that, you know, there's a hormone in the brain that's called acetylcholine, and you may have heard of serotonin or dopamine or noradrenaline. Well, acetylcholine is another neurotransmitter hormone in the brain, chemical in the brain, and it basically helps the neurons talk to each other around memory. And so the more acetylcholine you have there, the more likely it is that your memory and your cognition will be improved. And that's what these drugs do. They increase acetylcholine. And if you do want to start them, you go slow and go low, so 5 milligrams for 4 weeks, and then if that's okay, up to 10. And you do need to be aware of some absolute contraindications. So heart block is one of them, an active peptic ulcer disease is another, uncontrolled asthma is another. And you'd have to have a chat to the patients and the family around common side effects. And unfortunately, the list of side effects is quite long and not uncommon too. So you have to warn them about the potential upset gut. So that could be a bit of nausea, a bit of tummy pain, a bit of upset bowels. And also there's an increased risk of falls and confusion. And it's quite hard to sort of sell the drug when you're kind of saying, oh, this one will make you fall over and make you more confused. But I sort of frame it in the sense that, you know, there's also a potential benefit which would increase your ability to keep doing the things you love doing at home and staying at home. And if you do have these side effects, you know, as soon as you stop the medication, they're likely to reverse within a few days. And you need to keep in close contact with me about what's going on and give them permission to stop the tablet themselves before they come to see you, because some patients, you know, feel like they won't do anything until they've spoken to their doctor first. So that's the sort of way I describe it. Steph,
Yeah,
do you have anything to add?
No, quite often it's not necessarily the person who notices a difference, but the relative who says, oh, you know, they just seem, people sort of describe it like the light bulb's just a bit brighter, or people are just a bit more focused. So it's quite subtle.
Yeah, that's another really good point about how do you measure benefit when you don't have a blood test to look at a hemoglobin A1C or a blood count or whatever. And you can repeat your cognitive assessment tool, but of course, you know, that's a bit cross-sectional too. It depends how the person is on the day when you do the assessment.
And also that they're still getting worse anyway. You know, they are going to get worse regardless of of you doing the assessment. Do you know what I mean? Because it's progressive. So it's hard to measure benefit. But what you do notice is that if you stop it, sometimes people get worse. So that's also hard.
So I think that's usually when they've been on it a while, they've had a positive effect, rather than someone who's just been on it for a few days or a few weeks and then had to stop it suddenly from. Yeah, that's right. And you can switch between one from another, and I'd recommend you just look up therapeutic guidelines, because they've got some really great detailed descriptions about how to do that. And if you forget any of this stuff, you know what to do as well. I mean, the other thing is recommended is to do an ECG before you start to make sure they don't have a heart block, third-degree heart block, or something you've missed before. Yeah. So the next slide is look, I'm not going to another type of medication called memantine. I've never prescribed it myself, and it would normally be under the auspices of a specialist. I think, Steph, I don't know, have you ever prescribed memantine?
I've used it in the context of somebody who presented quite late and was quite agitated, and because sometimes it has got benefits for reducing some of the agitation that occurs, but only, you know, very rarely, really.
Yeah, so I think we're not going to spend too much time talking about that today, but it'd probably be in association advice with a specialist. And those side effects there are the same donepezil, by the way. So got to be careful about how many you list when you're going through it. Okay, and then the next slide. I've lost Beck too, Steph. Have you got Beck there on your screen?
No, she's trying to log back in.
No, log back in. Okay, yeah. Was a bit dodgy, yeah. So we talked about medication. So yeah, we had this slide up before, so it's just a good revision, really. And there are quite a few websites you can go and have a look at anticholinergic load. The main takeaway message there is, if you are going to start someone on a cholinesterase inhibitor, make sure you take them off an anticholinergic, because you've got two drugs that are working against each other. That's the first point. And the second point is that a lot of a little bit can end up being a lot. So you may not have them on a classic anticholinergic drug, but you might have them on a few heart medicines and a few other medicines, and all of them can have a little bit of an anticholinergic load, and when you add it up all together, it can make a big difference. So again, that just re-emphasises the need for a medication review, and to stop what you think they don't need, and get some assistance from a pharmacist if you're not sure.
And on the next slide, there are some tools that you can use to help assist you with
just a couple questions came through with that one that I just wanted to go to before we go to the next slide. So we had stop the medication when admitted to a RACF. Question.
with the acetylcholinesterase inhibitors. Yes, there is a question about when do you deprescribe donepezil, and probably it is at that stage 3. At that stage 3 time usually.
Yeah, my understanding. Yeah, so I guess if they've got very late stage and then they're not verbalising and they're in a bed lying there and they're not feeding and that kind of stuff, I for sure I would. But I think if they're still sort of transitioning and a bit independent, and then I wouldn't stop it. My understanding is advice is not to stop it because of the risk you may end up with a reversal in cognition, and sometimes that is an irreversible drop in cognition when you stop the medication.
The only other time I've seen it recommended to stop and switch over is if somebody does have some behaviours that are causing either agitation or aggression, and that's because memantine has more evidence for that, and also that donepezil apparently is more activating. So if you want someone to be a bit calmer, you might switch over to that one. But otherwise, yes, it's only really when you're palliative that the recommendation is to when you're deprescribing everything.
Yeah.
Perfect. Thanks, guys.
Right, was there another question? I can't see the questions. Were there any more?
The other one was basically the same thing. So would you consider a point in the disease progression where you would stop these medications?
Yeah, okay, I think we've answered that. Yeah.
There's a really good deprescribing tool for dementia called MatchD. It's I think
on the next slide. Oh, you've got the I think you've got the other version. I did do a version with MatchD. You can talk about MatchD, Beck, that's fine.
Oh, I was just saying, I would highly recommend looking it up. I really apologise. My computer seems to have dropped out. Oh, I'm back in. Hang on.
You can't see you though.
You've gone all Dalek. Okay.
I've now got two things.
Well,
I've just kicked the other.
I think I need to get a new server. Thank you. I'm so sorry. Yeah, MatchD though, I would highly recommend having a look at MatchD. It's very helpful because it explains the different stages of dementia and at what point you look to deprescribe various medications. But like you said, Steph and Pete, I think generally with the acetylcholinesterase inhibitors, I agree. I think you keep them on them if they have shown benefit in the past through until that stage 3 at least. Yeah, you can always add memantine in too if you need to.
So it's good you're back because we're about to start talking about your section. So on the screen now you'll see a stop start tool, which is just a tool from the UK which is specifically for older people, but it helps you to identify medications you should be stopping and should be starting, and that's all medications, not just talking about dementia specific medications or cholinergic burden medications. And I've popped into Sydney two references that are useful for those other ones that we talked about. So if we go on to the next slide, we're going to think about the second thing on our list of domains, which is function. And Beth, you're going to talk us through how do we approach function from a stage 1 perspective.
Sure, yeah. So I think essentially what we would like is to try and avoid de-skilling wherever possible, to try and maintain an individual's independence for as long as possible, and also to be able to support the caregivers and the family in helping to manage some of the practicalities associated with the change in function and also potentially the change in behaviour, which we'll talk about later. In an ideal world, certainly we would like to involve these allied health people. And I think part of the value of talks like this is that hopefully it will encourage us as GPs to involve the allied health people more. And the more we do that, the more commonplace it becomes. So this is gold standard stuff, and at the moment, very little is done in post-diagnostic support. So what we're trying to do is encourage you to think about how we can help avoid the de-skilling. And there are programs that have been done which have an evidence base. So there's a US-based program called COPE, which is caring for the older person in their environment. And that's a family-based program where skilled occupational therapists and nursing staff can assess the person in their home, look to their strengths, look to their interests, and also look to any unmet needs that they have or that the carers have, and try and work with them to address these. So the other thing that I think is also relevant is, especially in stage 1, this might be an opportunity to also learn some new skills which might be beneficial in the future. So I know I had people living with dementia during COVID, and they just weren't able to use Skype or use Zoom, and it was such a shame, because I think potentially if that had been a skill that they had become very familiar with before they had become before their dementia had become so significant, that perhaps they would have been able to maintain a lot more of their relationships. So things like that, you know, like how to use audiobooks, various things that might be useful for the future, might be early skills to learn as well. So things that the occupational therapist might be able to do is help in obviously doing the home assessments, which is part and parcel of most ACATs, but looking to change environment, looking to employ some tools to better assist with orientation, so assistive technologies, pill dispensers, alarms, things that will help with safety in the home, including things like organising your vital calls, or you know, switches for stoves, sensors. You can get watches which will alert people if the person's had a fall, or you can also get some technologies which, for example, will alert if somebody's left the house, so to speak. So those sorts of things can be very useful and reassuring also for the caregivers. What else? So we talked also about Pete mentioned speech, but speech can also be really helpful in terms of addressing more the language, but assisting in how to get around word finding difficulties, etc. Again, that would be something to start early in stage 1. I've written some other things. Let me just have a little check. Or another thing that I think is always important, and I try and do fairly early on post-diagnosis, is to direct them to the Dementia Australia website. I usually actually get onto the website and show them how they can access various help sheets, and also there's a main number that they can call or that their family can call. And I think there's another website I use quite a lot called Forward with Dementia, and that is a government sort of initiative which is actually international, but it's been specially designed for Australia, and that has a lot of information on where you can access these post-diagnostic supports and what sort of things to look for. So they're two really helpful websites that I'd go to. In terms of function also, and we talk about this a bit later, but physiotherapy, of course, both to address issues of frailty, and also just things like we've got here raised garden beds, you know, walking aids, etc. Also, people who are living with a dementia of Lewy bodies or a Parkinson's dementia, you know, these people particularly might benefit from specific physiotherapy for the Parkinson's style conditions as well. Moving on. Yeah.
So I was going to say the other thing to mention here too would be if you're not already sure, then it's worth finding out what local dementia programs are running in your area. So I think there's a lot, because I mean I live in a fairly sort of rural coastal area, and we've got two in the two large sort of city areas, and they're fantastic. You know, like it's an opportunity for carers and people with dementia to come together once a week, and there's proven benefit by attending these sorts of social gatherings together in terms of reducing the rate of decline of cognition.
Yeah, that's so true.
Often organised by the council or by other charitable groups, so you sometimes have to look a little bit outside the normal areas. But the PHNs are also, or have also, hopefully created some resources to identify where the local groups are. So hopefully Hunter New England's got the same sort of thing.
Yeah, and Dementia Australia will also often have education sessions, both for the person living with dementia and for their carers. So that's helpful too. I suppose some of the evidence, so for some of what we're talking about, there's evidence, for example, for the cognitive skills and that sort of thing, that it will actually sort of in the short term even improve some of the memory and thinking skills. But some of the other benefits are more around mood and maintaining sort of social connections and improved caregiver experience. And there is quite significant evidence now suggesting that all of these supports will help somebody stay at home for longer. So it's certainly worth trying to employ. So the other thing that often comes up, and this really is a whole talk in itself, is driving and dementia. And, you know, it is a very complicated area. Certainly you will have some people come in and it's very clear that they're not fit to drive. You'll probably also have some patients who do have a diagnosis of a mild cognitive impairment, and after sort of doing some appropriate assessments, you feel pretty confident that they are probably okay to drive. I think the tricky ones are those ones that sit in the middle where you're not quite sure, or also those patients who really probably are not fit to drive but are quite adamant that they still want to drive. That's the other difficult area too. I think it's important that you start having the conversation about driving very early, both in the sort of over 75 population every time they come in for their driving medical, just to start to lay the foundations of, you know, what would you do if you weren't able to drive, how would you manage, etc. but also then at the diagnosis of the cognitive impairment, start to have the conversation about driving, because it is important that when somebody has a cognitive impairment, it doesn't necessarily mean that they're immediately not able to drive. And so I think that's one take-home message, that it doesn't necessarily, a cognitive impairment doesn't necessarily mean that the person's not fit to drive, but it certainly requires a fairly thorough assessment. If we just move on to the next slide, I will just give a plug for Lee's the Health Network pathway. It's very helpful. If you go onto that website, it's very good, and you'll find also that a lot of these tests, for example, the trail making test, you can access through the health pathways. So the other thing is, of course, the Ausroads will have guidelines on dementia and driving too. The mini-mental itself is not a good predictor of whether someone can or can't drive, but certainly if somebody has a significant dementia where the mini-mental is less than 20, it's almost certain that they shouldn't be driving. I do think cognitive assessments can help you to try and discern whether or not somebody is fit to drive, and I think the MOCA is a really good tool to use. The MOCA has got the trail making test. It's also got the clock drawing test within it. It's just a modified mini trail making test, but it does give you some sense of how their visuospatial reasoning is, of their working memory, of their ability to flip between tasks, their mental flexibility, etc. Some of those executive functions. And also it provides you a baseline to continue monitoring as well. Because driving consists of so many different cognitive domains and also different functional domains. And it might be that somebody who has a mild cognitive impairment, it may be that those other domains, for example, if they've got some sensory impairments like hearing loss or change in vision or, difficult mobility, perhaps cumulatively that might indicate that they're not fit to drive. If you have concerns, then your options would include a referral to getting an OT driving assessment, and or a referral to a geriatrician for an opinion on fitness to drive. Often the geriatrician might refer for an OT driving assessment. And the OT assessments can be useful not only in helping discern whether someone is or isn't fit to drive, but potentially they may be able to assist in some sort of rehabilitation therapies to try and help the person continue driving for a period of time. Do you think that covers everything, Steph, in a nutshell?
I think that does, yeah. We can move on to the next. I think the next two slides just show the trail making test, which
they are. So yeah, the trail making, if you're not familiar with the trail making, so there's an A and a B. Trail making A is simply numbers, and this is just a sample. There's 25 numbers normally, and the average time for you or I would be probably about 30 seconds. I think the average time for a 75 to a 98-year-old is basically a minute, and certainly, and then the trail making B test, you're going from
next slide.
Yeah, we'll do the next slide. You can see there's numbers and letters, and so this requires quite a lot of mental flexibility and working memory to be able to go from a number to a letter to a number to a letter. And I think getting this test in under 3 minutes. So if it takes longer than 3 minutes, as a rule of thumb, that might be an alert that there are some concerns in regards to this, and would prompt you to do further assessment, really.
think you've already said the things on this slide already.
Yeah.
All right, so just thinking now about the third domain, which is psychiatric. I personally think this is something that we kind of miss a lot, probably because we kind of assume that people with dementia maybe can't do psychology, but I have had the experience where I've got a really good psychologist who has an interest in dementia, and so I've taken to referring quite a lot of people to her, and even in stage 2 they still have a benefit from having psychology. So particularly people who are experiencing depression or anxiety symptoms, but even just in that post-diagnostic period when you're having that kind of adjustment to that life-changing diagnosis, having the opportunity to have some psychology and cognitive behavioural therapy, even just a safe space to talk to someone, is really valuable. So I make that a priority. And there was a research paper last year that actually showed that the incidence of suicide, people dying by suicide, increases in the first 6 months post-diagnosis. So it's definitely something that we should be thinking about. But not only for the person living with dementia, also the evidence suggests that the earlier that a carer has some psychological support for themselves, the more likely that carer is going to be able to support their loved one for longer. And so trying to start this as an early measure, because that person is also experiencing grief and loss in association with that diagnosis and the ramifications of that. So it's really important that we contextualize it in terms of the whole family. So yeah, so advocating for a mental health care plan, thinking about prescribing antidepressants, that might be something that you choose to do. And then we also have developed something called a delirium action plan, which I know is in the health pathways. And this is because people with dementia are more likely to develop a delirium. So even from just a slight illness or perhaps constipation or just being more tired, you know, if those combination of things happen at one point, that person could become quite significantly confused or agitated. And so having a delirium action plan, which is on the next slide, is a bit like having a COPD action plan. It's a useful tool that you provide to the family so that they know the signs and symptoms of somebody who is likely to be unwell because of delirium, and that they can present earlier to us in general practice to perhaps avoid unnecessarily hospital admissions. So if you move on to the next slide, Sydney, I think you'll see that. Yeah, so you can download this off Health Pathways and give it out to families when you see them. And as you can see, it has got on there the causes of delirium, as well as you know, notification of who your GP is. So if we go on to the next.
The other thing just to note there is that if you do want to prescribe an antidepressant or anti-anxiety medication, then citalopram, or I know therapeutic guidelines also recommends escitalopram, which is obviously its close cousin, are reasonable 2 drugs to commence initially, and the older the person, the lower the dose. So again, I think if you're over, I can't remember off the top of my head what it said, it might have been over 85 or 80, then you start on half the dose, but I generally start on half the dose anyway, because there's no harm in going low and going slow. And that even a small dose can sometimes have quite a meaningful benefit to reduce anxiety and lift mood a little bit.
That's right, yeah. And also, you know, because sometimes it can be difficult to know with some of these other behaviours that are occurring, how much of them are related to the dementia itself and how much of them are related to mood disorders. It can be quite difficult to pick up. So it's always worth presuming that there might be some mood changes and treating that first, as well as doing some of the non-pharmacological things on this slide, which I think you're going to talk about, Pete.
Yeah, so I guess having talked about cognition and psychology and function, it makes sense that you're going to have some behavioural issues potentially too. And there's such a massive crossover, isn't there, around, you know, why is it the patient is feeling agitated? Is it because they can't find the word that they want and they can't communicate? Like, one part of their brain is saying, you want to communicate this bit of information, but the part of the brain that's trying to say that is not working anymore. I can't imagine what that must be like. So you can imagine that people would, end up with feeling agitated and frustrated, and eventually you may also, or maybe part of the dementia itself, or as a result of that, become very apathetic and socially withdrawn. And so, it's really important that these symptoms are addressed. And again, if you've got access to another local occupational therapist in your area, having them come in is really helpful. If you don't, then again, referring to one of these local groups. And if it's not a specific dementia group, it might be, MenShed. It might be, an appropriate volunteer place that they could go to at the local op shop or something like that. But just something to keep them socially engaged can sometimes make a big difference. Simple things like maintaining routine, having things that they know, they're aware about, that they're still aware of, like music that they're familiar with, photos that they're familiar with, their family, can make a big difference in helping to reduce challenging behaviours. We talked about speech pathology, day respite. I know, what's that referring to actually, Steph? I know respite in terms of aged care facility respite. I don't know what day respite is.
So there are some programs, so for people who might be in stage 2, or for perhaps people who are living on their own and don't have the ability to, go out and socially engage without lots of support, you can have a sort of day program. We have quite a few in South Australia where there'll be lots of different activities. People come for the day, often transport is provided. It does 2 things. So it helps that individual stay connected. Sometimes if people do have carers at home as well, it helps the carer have some time to themselves as well. So they're often from like 9 till 3.
Right.
And some people go a few days a week.
We don't have them here. That's why I don't know anything about them. They sound awesome.
Yeah, it's pretty good.
Yeah. And that last point there, we can't keep re-emphasising that enough around education to the person and the carers. And there are, and in terms of education, we go to the next slide. So there are some specific organisations that you need to be aware of. So the main one is Dementia Support Australia, which is a federally government-funded organisation that's open 24 hours a day, 7 days a week, 365 days a year. And I give that number to the families of people living with dementia. You can ring it yourself as a practitioner. They can ring as a carer to try and get some support. If a person's waking up in the middle of the night and there's a crisis, or they want some tips around sundowner syndrome or wandering, this organisation gives some really helpful tips and support on the phone, and they've got access to resources as well.
I was just going to say that sometimes that education bit is actually just empathizing, like you said, with the person in front of you. So like you said just now really clearly, I can't imagine how frustrating it must be to try and want to communicate something but your brain just won't let you do it. And I think what we can do is actually show some empathy about how that must be for people, because I think that's actually really nice to acknowledge that might be how someone is feeling. We might not have all of those yet, all those really cool allied health professionals that are going to help us, but we can actually do that education and explain to the carer that it must be how frustrating it is, because I think sometimes they might not understand the frustration that's being experienced, and that is some of the problem with that communication between people. So I think that's a job we can definitely do.
Yeah, definitely, Steph. And also just explain to the family, asking them and saying, what are some of the behaviours that are going on at home that you're finding challenging, and unpacking them. And the carer may not be understanding that some of the behaviours are actually part of the dementia. They may be blaming them on, a 30-year-old marriage or something, like that. Which unfairly impacts the person living with dementia. So trying to unpack that with a family and explaining that that's a classic sign of someone who's declining or whatever the situation can be really helpful.
Perfect. So we're rapidly running out of time, Beck, but if you can do this one quickly, that would be good. I think this is the one that we're probably most comfortable with anyway. We do this quite a lot anyway, don't we?
That's right. So yeah, I think, you know, bearing in mind, it's really important that we see this person holistically. Things like vision, hearing, dental, bones, and falls are really important, and often they get a bit neglected. So I think certainly trying to address these quite early is really important. Also, you can, of course, use care plans, so your EPCs, to make referrals to the physio or to make referrals to the exercise physiologist. And in your area, there usually are some allied health staff who are happy to do home visits as well. So again, it's important to try and find some people that you can liaise with to do this sort of thing. Sometimes within their care package, this can be included. So under the Commonwealth Home Support Package funding, you can sometimes get physio or exercise physio to come and do some assessments as well. Similarly, dietitian, speech path, etc., might be useful also in your referrals as well. And of course, most health networks will have some sort of falls prevention program, and I would strongly advocate for that too. Yeah, I think that's it in a nutshell.
Perfect.
Yeah, that's the best thing. I just the dental one as well, because dental pain can often be. I'd stress having the dental checks early, because dental pain can be misrepresented as other types of pain, and then once you have a later stage dementia, going to places like a dentist can be more challenging. So getting that sorted out in the early stages is really helpful.
Yeah, that's right. And it's often missed. And same with bone health. I think when somebody receives a diagnosis, it's quite reasonable to ensure that you've done a bone density assessment, because unfortunately this cohort will develop frailty earlier, and thus their risk of fall is greater too.
So this slide just shows you all of what we've just said in one picture. It's quite a busy slide, but these are our GP management plans, which are available on our website. So you don't have to remember everything or go back to the slides. You can just download these. And so that's really why that slide is there. The next slide is going to be talking about the carers. So Pete, we need to think about the whole family. What can you tell us about carers?
Well, we've talked about this quite a lot already, Steph, I think. So I think the main basic points are here is that there's a massive number of carers in the community. They tend to be more likely to be women, and it's unpaid caring work, and don't underestimate it as a GP. And I think we all probably know that already, because we're all probably already seeing it, or have family where that's already happening. And make sure that you're looking after the carer, or your colleague who might be seeing the carer, not you. Whatever GP that the carer has a GP to, because they will at some stage definitely go through a phase of exhaustion or depression or needing a break with respite, and alerting them to that likelihood and what to do when it happens is really important, because often, like anything in life, just knowing that something may happen and what to do when it does relieves a lot of anxiety.
And don't underestimate how powerful our words can be. So I had a lady who was really doing, she's done at least 10 years of caring already. And when she met me for the first time, she said, I don't know how long I can carry on. And I said, oh, I don't know, maybe Christmas. And this was in April. And I just kind of said that as a thing. And then she said to me at Christmas, I've made it till Christmas. And now I've reached my time, and I was like, I didn't realise how powerful that was. I would have said sooner if I, well, I didn't realise. But you just have to sort of think. Sometimes it's about us helping give permission to people to stop doing that intense caring, but by whatever means that they need to do that, because people find it really hard to let go. And so some of our job is that, but as you say, we do this in lots of other conditions as well. I think
the other thing that I sorry, Beck, is to acknowledge the carer. So I often say to people, thanks for caring for your aunt, and they kind of look at me like, strangely, and I say, well, it's important to acknowledge what you're doing. Like, like I want to acknowledge what you're doing here, and that does make a difference. They get it, and they are thankful to be seen.
And there can be a real guilt associated with the, when it may come time to be considering aged care facilities, there's often a real guilt. And again, I think that's where an early diagnosis and, if you do have a person living with dementia who is understanding of their spouse or their caregiver, to have that discussion early to make it okay that there may be a time when it happens. I think that can really alleviate some of that guilt, and is another reason for a good early diagnosis. And just one other thing we've mentioned is that concept of respite. I've had it a few times now, trying to familiarise somebody fairly early on in the process with somebody who can be their respite carer can be also really helpful, because sometimes if the dementia has advanced too far, they're very unwilling or unlikely to necessarily go with someone else. But if you've started the process quite early, it does make it a lot easier moving forward. Sorry, just a quick insight.
Good. Next slide. So I think we've already mentioned most of this. So yeah, we can move on to the next slide. And this is just a reminder that you don't have to do this all alone. And I think we've emphasised that quite a bit as well. Make use of the other people in your health professional community and find out who they are. Making those connections is really useful. So hopefully we have managed to help you to feel more confident in making a diagnosis and initiating post-diagnostic support. We've talked about a timely diagnosis and how that's important for instituting post-diagnostic support. And we've also described some of the non-pharmacological measures which can really improve people's quality of life. And so hopefully you feel a bit more confident. We've got some resources. So I mentioned before the Dementia Training Australia resource page. You have to log in at the moment, but once you're in, you have access to all the management plans and it's freely available. And we also have our podcast, which I think we mentioned last time as well, which fills in lots of gaps for stuff that you haven't perhaps heard in the last 3 hours of us talking, or if you want to go over anything, we also go over everything again. And that's it. Lee, I think, are you wanting to talk about your health pathways again?
Yep, I might do that. So, sorry, I know we've got to the end, but here we go. Trying to do the sharing my screen.
It looks good on our end, Lee.
Sorry? Oh, is it
looks good on our end? Yeah, it was.
You can see the health pathway?
It's gone now.
It was there and now it's gone.
I'm glad you're having trouble too.
There we go. Got it.
We're good. Okay. Well, thank you so much to Steph, Rebecca, and Pete for a great presentation. Really comprehensive and really useful. So I guess just quickly to say that pretty much everything that you heard about tonight is on the Hunter New England Health Pathways. And what I thought I might just quickly do, that will just take a couple of minutes, is just show you where some of that information lives, just to prove to you that it's actually true, that it's there. So on, for example, the dementia and cognitive impairment pathway, if you go down to assessment, then you'll see under here the 5 domains of dementia, each of which have a bit of a drop down there to give you some more information. And then if you scroll down a little bit further, you'll recognize that slide, which was about 4 inclusion criteria and 3 exclusion criteria. Again, with the drop downs, you'll see that. Under management, if you scroll down a little bit, then you'll get down to review medication, and in particular here, reducing or ceasing medications which may impair cognition with a drop down. And under here, you'll see in particular medications with anticholinergic effect. And if you click there, you'll get a list which separates them into ones which have a bit of a higher anticholinergic effect and a lower anticholinergic effect, depending on each of their classes. And there's a link here, which I really like. It's kind of fascinating. Sorry, that not quite the right acronym. It's the ACB calculator, which if you click on that, it'll give you a sense of exactly how much, well, a bit of a sense about the anticholinergic burden that you're hitting your patient with. That's it here, for example. I was just playing around with it before. This was one of my patients who was on oxybutynin and furosemide, had a score over 4, and this is only in the last few months when I stopped those 2 medications, really remarkable improvement in function. So a very a powerful tool and a really good reminder about things that can make an impact on our patient. There is also...
Well done.
Sorry?
That's great. I said good on you. That's great.
Yes. I'll accept the pat on the back. Thanks. So, look, but I will admit though, it wasn't something I thought of straight away. So somewhat embarrassingly, the patient was on those medications for a few weeks before the penny dropped. So, but I got there eventually.
Acceptable, come on.
got there eventually. So
yeah.
There's plenty more information on that particular page, but let's go to the next page, which is about medications for dementia. So also was mentioned earlier in the talk was about the PBS criteria for cholinesterase inhibitors, which you'll find here in this drop down, and also some of the precautions that you might need to take before starting something like that. And an ECG, for example, was mentioned there. Under starting treatment, you've got plenty of information about the anticholinesterase inhibitors and memantine. So that's all there with little drop downs with doses and how you would titrate them. And also the laundry list that Pete mentioned of the side effects, which just goes on and on and on. And let's not dwell on those. Let's not dwell on those.
Don't print them out and hand them out.
That's right. Let's not do that. There is also specifically, we talked about deprescribing. So you'll see a particular drop down about deprescribing, which includes, for example, there was that particular point here about transition that was there as well. And somewhere there is another link somewhere to match these. Sorry, that was on another pathway. Fitness drive was mentioned, and we also have here under assessment the examination and screening tools. So under here, you'll see the trial making test, the A and the B, the clock drawing test, and the intersecting pentagons. Good and ready for you to go. And yeah, look, I found this enormously on the same patient that I mentioned before. I was having, this all came up at the same time. And it was, I have to say, enormously reassuring from my perspective that we were able to go through these tests. We actually failed. The patient wasn't able to get through these tests before we stopped the oxybutynin and the furosemide. But then after we stopped those 2 medications, was able to get through these tests. And I felt so much better about proceeding with her being able to drive. So if as much benefit for me as for her, I think, in terms of how I was feeling about the situation. So that's
just a quick point there. We might need to feed back to the health pathways, but Steph and Beck, correct me if I'm wrong, but I don't think they're screening tools technically, are they? They're more of an assessment tool. In other words, we wouldn't recommend you do them on every person of a certain age in the population. And they're better off done. They have a higher predictive value generally if they're done on a person with a known cognitive impairment than just doing it on anyone.
That's a good point. Yeah. Good point. So it's very contextual. And
good assessment.
Yes. Here's the health pathway, the specific pathway on BPSD. And so that has information about non-pharmacological interventions as well as pharmacological interventions, including the antipsychotics, but also, as Pete mentioned, antidepressants, in this case, mentioned citalopram. So that's there. In terms of, there are other pathways, which I won't go into the other ones in detail now, I'll just quickly brush over them. Another one on deprescribing, another one on carer stress, non-clinical dementia community services, which lists a bunch of resources here, but also particularly for specialist dementia services, what's available in our region, and particularly, as was mentioned before, about not just dementia assessment, but also behaviour management support services, which includes links to the services that were mentioned before. So the Dementia Support Australia, which is essentially sits under here. So you see that as a national option, but then also we have some local options as well here. So help is at hand and easily accessible by health pathways. There you go. Thank you. Thanks for your patience, everyone.
Such a great advert. That's perfect.
Well, thank you everyone for today. That was wonderful and so informative. I don't think anyone minded running over time because that information needs to get out there. Now, I'd like to thank you all individually, but there's so many on there tonight. But thank you all for coming back to our second part 2 of tonight. Now, as reminded in the beginning, please fill in the evaluation survey that will come to you after, as we need to capture your RACGP number to upload your CPD education activity hours for RACGP. But until next time, thank you all and have a good night.
Thank you.